Because from what you tell me, obviously you're a very creative person, very innovative, and then medicine is a field that's more or less very repetitive. It's like we just do protocols that have been done sometimes for hundreds of years.
Right.
So I don't know, how do you do it? Do you not struggle? Does that creative side just pop in the middle of surgery and just say, what if I just do this completely differently?
Well, I think hand surgery particularly is like it really harbors a lot of creativity. I mean, if you ever worked on a rheumatoid hand, you'll know that there's no two rheumatoid hands built the same. I mean, sometimes it looks like a bomb went off in there, and you got to be pretty creative. You got to use different tendon transfers, different tenodesis techniques. I mean, you got to use what you have. You never really know. Nothing will prepare you for like an 80-year-old rheumatoid hand. And you go in there and you don't even really know what you have to work with. So being creative is a prerequisite for hand surgery, of course. I would think that if you, in some cases, sports surgery can really harbor a lot of creativity. This is why I wasn't really drawn to joints or spine, because I felt like it was advanced carpentry. It was really algorithmic, step by step. No disrespect towards them. They do great work.
You do know how to make friends.
I love my joint guys. I mean, like I do. You need that. There are some cases. I mean, my carpal tunnel is like 8 steps. I mean, it's very algorithmic. So, but and I know when they do like revision hips and knees, it gets really really creative. But I did go into hand surgery because it does. You have to be extremely. It's really it really. I would say creative and artistic. There's a science to medicine, and there's definitely an art to medicine. We talked a lot about when you operate, when you don't, but let's face it. I mean, you get in there for trauma. It is really an art. Setting tensions on tendon transfers. Every bone quality is different. Every skin tissue is different. Every patient has different expectations. The art of medicine is sometimes, and many times in my world, the most important part. Anybody can slap a plate on things, but do you really want to, like, okay, I'll give you an example. I saw a high-level college football player today with a scaphoid fracture. I mean, that player's goal is to get back as soon as possible. Opening that up, and it's acute. So, I mean, I'm going to perk this. That gives a big advantage because there's no incision, quicker healing. Could probably get him back to playing a lot faster. Same thing with phalanx fractures, metacarpal fractures, being able to perk those and put intramedullary screws. That's been a big push in our field. I have seen patients. I mean, you had, a common injury for older patients is they fall, they trip over something, and they break 3 proximal phalanxes, and they get that apex bolar deformity from the pole of the extrinsic and the pole of the intrinsic. So they're bad injuries if you don't fix it, because they get this classic S-shaped deformity. They can never make a fist. They get super small. We used to classically just throw them in a splint and they would never make a fist again. And I'm talking about older patients. Now what I'll do is I'll fire some intramedullary screws in there and buddy tape their fingers and get them moving. And I promise you never saw results like that. They come in at 6 weeks and they're almost making a fist. 3 months, they're making a fist with no pain, with healed fractures. I mean, you just never saw that result with no lag. They don't have an extensional lag. It's crazy. So the art of medicine, if you follow the textbook, it says, okay, you can treat those conservatively, or you could do Eaton-Belsky pinning. You could put K-wires in them. You could put plates on them, which never do, because once you open that tendon, they'll never move their hand again. So the art of medicine, the book tells me to go slap a plate on there or do a pinning, but the art of medicine says pass a screw in there because they're going to do better, because you're going to get them moving quickly. It's hard to move a K-wire sticking out of your hand. It's really hard to break up the scar tissue with plates. So the one thing that I really hate is when you have a patient with a really good looking x-ray, but a terribly functional hand. So Um, or even like go back to the skateboard example. I mean, like there was reports of people being in a long arm cast for 9 months. I mean, not even that long ago, like 20 years ago. So can you imagine putting a kid in a cast for 9 months? What that would do to the kid's psyche or family? He'd miss a whole year of sport. That's not that's not science. That's there's no where's the art in that? Where's the fun in that? Like how do I get this kid back? How do I and am I really listening to this kid's goal? Personally, if I was 12 years old and I had to be in an arm for a cast, I would just quit sports. And I wouldn't be able to, I would be missing out on all these huge milestones in my life, swimming in the summer, hanging out with friends. I mean, we have to think about that stuff. Like, life is important. And
Yeah.
if we don't get them moving quickly, this quarterback doesn't play his senior season, if the kid doesn't go to prom, I mean, these are really important things that we have to take into consideration. And now, Grant, I love the fact that surgery is, you know, people are talking about that. I'll give you another example. I had a young girl, was going to prom, fell off a horse, broke her humerus. Okay, broke it in like February. I went in, had to do. It was a Holstein Lewis fracture with radial nerve palsy. So I went in, I moved the nerve out, wrapped the nerve, fixed the fracture. Pretty simple, straightforward. She did fine. She healed it. But she was, concerned about the scar, right? That's an unsightly scar for a 17-year-old girl. So what we did was we did plastic surgery closure. At 3 months, we were starting scar microneedling. We were doing a lot of plastic surgery techniques to get the scar down. She ended up not keloiding, got a really beautifully looking scar. I mean, you can't even see it. And then for her prom dress, she put a little makeup on, couldn't see the scar. Had beautiful pictures. That was her goal. And that's important to me, right?
Yeah.
Like a lot of people would have laughed at her and be like, "We don't care about your scar. Who cares about your scar? It's your arm, right?" I'm like, for me, it's like, okay, well, tell me how I can make it better. And we took the time to listen to her. And her mom was really sweet, and we were able to do some things and think outside the box. Again, it's the art of medicine, right? I mean, yes, fixing the humerus is probably the most important thing. Fixing her nerve is the most important thing in the world. Then her humerus.
Mm-hmm.
But for her at 17, going to prom and having good pictures and not being, anxious and nervous about a long, because you know how long those scars get on that
Oh yeah.
humerus. They're never small because you got to get the triceps way back.
Yeah.
So yeah, so I think one of the things that I think is fun about medicine is you're always trying to challenge yourself to take into consideration what the patient goals are. Um, I always ask questions. So every time I have a PA or a student with me, and they report back to me, the first thing they have to tell me is how old they are and what's their dominant hand, what they do. And I'm absurd about that. They'll be like, I have a 25-year-old kid with a fracture. I'm like, what is their dominant hand? What do they do? Okay, I have a 25-year-old carpenter who's got a phalanx fracture in his dominant hand. Okay, that tells me a lot more than 25-year-old with a phalanx fracture. So when you word it like that, you've now emphasized that patient's life, and you've made it. They're not just an X-ray anymore. They're a person with real life goals. And you, as a surgeon, you would know exactly. Like I think about sometimes, like if I had a scaphoid fracture, what would I do? I'm getting a perk screw immediately because I would not wear a cast. If I had a phalanx fracture, I'm getting a perk screw. If I had a carpal tunnel, I wouldn't live with it more than a day. I'd be like, just do it endoscopy. And I wouldn't do it because how carpal tunnel, how trouble it can be. So I always ask myself, I'm like, what would I do in this situation? What would I do to my wife? What would I do to my child? And I think when you start thinking about it that way, you end up making more right decisions than wrong.
Yeah, I agree. Um, but like, how do, because not everybody is equally creative. Some
Yeah.
people are just, okay, repeating whatever has been done for so long, and you know, they do it like you said. Maybe they're in that phase of their life where they're just trying to do as much as possible, and have a different focus instead of like being this patient centered. I mean, we're all patient centered in a way, whether no matter of our career we are at. But is there something? Is there something you see in the healthcare system, in the U.S. healthcare system, that encourages medical innovators, or if there isn't, does it need to become incorporated, and how can that be done?
We we all know, like, let's just say like a PIP fracture dislocation, by the way. Okay. So you and I both know that you go in and open that, you're putting little pieces of eggshell together, especially in an osteoporotic patient. The moment you open that and start screwing around with the collaterals and trying to pin everything together, it just, you get into a hole that you can't get out of. So in some cases, it's better to go just fuse the finger, or in some cases, it's better to X fix it and just keep it out the length for as long as you can and get some sort of healing. But then you've always got someone arguing about what they would have done, and in hindsight, they could have done this way. No, you can't. Anyone who's ever been literally inside a PIP fracture, and in an older patient, which is eggshell osteoporotic bone, the screw's not holding any piece. And you kind of just wish you didn't even, like, you kind of wish you weren't even in there in the first place. Like, you just X fixed it. So what I find ironic is that in a field that should be celebrating creativity, punishes you, because then they can go say, why didn't you put a plate on it? You know that wouldn't have worked. That's not the gold standard. You know what I mean? Like X fixing it will get a better result, because, and this is the hardest part, and this is what I said before, you're not treating x-rays, you're treating people. If I have a complex fracture dislocation on my PIP, I mean, I'm talking like a blown up pilon one that, like, X fix it. If it doesn't work, maybe do a heavy hamate later or whatever, or fuse it. But don't go in and slap a bunch of plates on it and little 1.2 millimeter screws, because it's not going to work. It's just going to make it worse. It's going to create scar tissue. But if the gold standard is to go and fix everything with little screws, then I would challenge that person to be in that situation at least once in their life and know how difficult it is. So I think being creative is also understanding that I would rather have a more functional, painless finger than a good-looking X-ray. But I mean, like when you start bringing in third opinions and these subjective opinions, it becomes very difficult and very hairy. And sometimes we're treating, and I hate to say this, but now we're creating a society where we're treating X-rays, not people. We're treating MRIs. My favorite is tennis elbow. I mean, how many times do you get an MRI on tennis elbow where there's always a tear? Every radiologist says high grade tear. I mean, all it is water change. And I mean, MRI is nothing but an estimation of water content. We all know that's a magnet, right? So I have to go get an MRI, which is going to charge the patient $300 to $800, probably the medical system another $3,000, to tell me that there's water content in a tendon that hurts, which I know it hurts because I palpated it. And then they want surgery because it's torn. It's not really torn, it's degenerative. But I mean, so it's like, and then they get the report, right? My favorite is they get the report. It says, a tear of the ligament and the tendon. The ligament and tendon are one and the same. They literally, I mean, it's like, how can you tell the difference? So then you got to go repair it because the MRI says it's torn. How could you live with a torn ECRB, right? So, I mean, like I said, that's the really crappy thing about medicine is that's not being creative at all. That's algorithmic. That's the opposite of what we should be rewarding. So you get some poor schmuck who's like getting paid to do surgery they shouldn't have done because an MRI says they should. So, I mean, but again, lawyers aren't doctors. Like, they don't know. They've never treated thousands of people with tennis elbow. They would know that it's a condition of like a pathway. Dr. Ring, you say it's a pathway to middle age. It happens to healthy people doing healthy things. And I rarely see people who play tennis that get it. So I think what we should do is reward excellence, reward people who are, trying to do good things. They're having, they're not cowboys and doing things completely out of left field. They're honest, but not everybody's going to have perfect results. And I think people who are striving to do better should be rewarded. And I think people who are not doing it shouldn't necessarily be punished horrifically, but like sort of steered to do better by incentivizing them in whatever way is manageable. Like saying, look, you can get paid more if you do a better job. You can get, whatever it is, but incentivize them. Like, we're too quick to punish people, which then makes them. I don't think that negative reinforcement is going to make better surgeons, in my opinion. Reward the good ones. Really, I mean, and anything like have a certain standard of doctors that can sort of create what this have. I would rather have 100 hand surgeons argue about what you would do with a blown up pilon fracture of the PIP joint than some artificial non-medicine lawyers or whoever, or peanut gallery people that are going to say, oh, the X-ray doesn't look right. Let's face it, you don't need a perfect looking X-ray to have a functional finger. You need it to be out the leg, and you need it to be articulated.
Yeah.
So you just I really think that part of American society is that we put, not us, but I think whether it's the lawyers or the insurance companies, they put too much emphasis on the objective findings in the X-ray or the MRI, which aren't always. The positive predictive value of an X-ray of a MRI can be very deceiving. I think we should put more trust into the art of medicine. That is by having good doctors get together and figure out what is our standard of care.
Yeah.
But because there's no book on it and there's no measures.
Yeah.
I'm willing to put up my results in front of 100 docs that do this every day and say, you could have done this, you could have done that, could have made it better, rather than 100 like peanut gallery people who are making laws and regulations that have never actually been in that situation. So I think if we're going to judge the industry, we should be doing it with people who are actually doing it on a day-to-day basis.
Yeah, 100%. And when you see any other field, like, the technology and technology related innovations, they're high iterations, right? They bring in and try something out, and it's just a very quick cycle every single time where they perfect their innovation almost at every step. So I feel like there also needs to be some sort of wiggle room in medicine for that, to really use especially nowadays, the available technology to just advance and make patient care even better. But it just cannot be the old way of having to take so many years, and people who don't really have much of beef in the fight being involved and stuff like that. So just give, like you said, the people who are doing the actual work to actually have a say in innovation and creativity.
Well,
Uh,
I think it's so great when you go to when you meet someone like you who has a different sort of background and a different like setting to operate. I learn tricks from you because you learn tricks from other people. So
yeah.
if I sit there and stay in a small town in Savannah, Georgia, and do it the same way every time, I'm not learning. I'm not expanding my playbook. So by talking to you, seeing how you do it, it's making things a lot more diverse
Oh
because
yeah.
you're just being way more creative.
You have to be more creative. It works for our setup because we are resource constrained, and it's to our advantage that rules are not as strict, because there's always this understanding, have good intent towards their patients. So we're given more autonomy, and through that autonomy, we're able to help using whatever we have that is accessible to us. But it really does make you creative, because you might not have everything you wanted. You know what I mean?
Right.
Yeah. So, but you've been in the African setup. You've done surgeries there. So what was that experience for you? What did you learn from that? And you just touched on it. And I also want to hear how relevant your innovation is for our sort of environment, for the
Sure.
African setup.
Well, one of the greatest things about doing mission work, particularly in Africa, is the thing that we take for granted a lot here in the United States is that the patients there are just they do respect doctors. It is really clear that they will line up for hours and days just to see someone who's trained in whatever specialty it is. So to have patients really listen to you, to really admire you, in some ways revere you because you've spent 30 years of your life preparing to operate on people. is quite humbling, but it is also a breath of fresh air. So going over to Africa, the first thing you notice is that we all look the same on the inside. We all have tendons and nerves all look the same on the inside. So it doesn't matter what your background is, what your station in life is, what your skin color, what your hair color, what your gender is. The moment you open up the skin, we all look the same. So that is the beauty of it. And we all heal the same. We all have the same biology. So that is that makes the playing field very standardized. The difference is that the amount of respect and the amount of it's actually quite humbling. Like, you're just not in the U.S. It's just, you just don't see that. Like, I mean, even in rural towns, like, I mean, they listen to you. They treat you very well. You're like revered in some cases, which is very humbling. It's also a little unnerving because you're just not used to that as a U.S. doctor. You're always used to that person who's a skeptic, or the family member who's going to try to challenge you, and they're going to Dr. Google you, and it's like, okay, you're always waiting for the argument. You don't have that in the plan, just goes forward. So in many ways, a lot of the hurdles to medicine are sort of erased just on the sheer nature of the availability of a surgeon. So that makes it very, very nice. The challenging part is, you guys, I mean, you do not have the resources that we benefit from here. I mean, even whether it's OR lighting, OR tables, X-ray, as you've seen, you guys have to be extremely creative, because you're getting a pan full of, in some cases, an assortment of X-rays, or assortment of screws and plates that you kind of have to put it all together. So you're cooking like with like, you know, you're cooking a 5-course meal in your backyard kitchen, as opposed to like a 5-star French restaurant, right? You don't have all the resources. So that makes it kind of fun, right? Because you have to be super creative. What I found that in terms of the future of X-ray, a lot of micro-C, which is now OXOS, was actually sort of envisioned when we used to go to Honduras with a group called Podemos. And at that time, we had only like a little digital dental X-ray, which was really small. I was supposed to shoot teeth, but I could get fingers kind of with it. Very rarely I couldn't get in the hand that wasn't powerful. So having an X-ray that can do everything, the whole musculoskeletal system, was a goal for me was back when I was a resident, because it allowed me to start the treatment plan for orthopedics. Orthopedics begins and ends with an X-ray, almost everything. Whether it's generic wrist pain to fracture to complex arthritis, it starts and begins with an X-ray. So it's really hard to start the whole treatment cycle when you don't have the very basic form of diagnostics. And I can tell you, I can pretty much treat everything in orthopedics with an X-ray and an ultrasound. I don't rarely need an MRI, and I really need a CT scan. Those are luxuries that we have if we need them. But how often do you need an MRI to prove there's an abscess? How often do you need an MRI to prove you got a rotator cuff tear? I mean, at that point, you're just sort of satisfying the insurance, company. So you can do a lot with X-ray. So I figured, and I looked at my numbers one time. I shoot probably 80 X-rays for every MRI or CT. So it's crazy. Like, I mean, like I said, 100 patients come in, almost everybody gets an X-ray or a follow-up X-ray. I may order one MRI the entire clinic. So it's like, same thing in like Africa. Like, we'll see 50 people. Nobody needs an MRI. They could get an MRI, but I mean, you have to take them to the next city at 500 miles away. And they'd have to pay out of pocket with money they don't have. So, and by the time they get the MRI, it's a week later and we're gone. So for us, like, I mean, having an X-ray at your disposal, a battery-powered X-ray, for me was just absolutely paramount, because we could start the whole treatment cycle. And in many ways, we saw a lot of congenital deformities. I don't know if they're missing an ulna or radius. I don't know. I mean, you start with an X-ray and like, oh, wow, I know exactly what they have. They got radial longitudinal deficiency, which I diagnose in X-ray. And then I can go back and backfill in all the other things that are associated with that disorder, right? You start diagnosing bacterial, radial longitudinal deficiency, Apert syndrome, all these things that we can go back and now looking for, like heart defects, vertebral defects, esophageal defects. And you started with a simple X-ray, and you're able to diagnose that kid's entire genital condition. And I can't tell you how many times I've been on a mission trip where we diagnose someone with an atrial septal defect or a heart defect based on a musculoskeletal defect that we saw with a simple X-ray or a simple exam. And
Wow.
I mean, I could go on and on. I don't want to bore you. Med students probably still know all this stuff about APERTs and Prader-Willi and all that stuff. Bacterial, but a lot of times the first thing that they're sent to a doctor for is their hand or their feet, or the face, because that's what you see, and you have the ability to change this kid's life, to get them to a hospital to go repair a life-threatening defect because you're able to diagnose it. And then the X-ray just gives us a little bit more, way more power to do things like that. So our goal for OXOS is to create an X-ray machine that is so versatile, and I don't want to say cheap, that's a bad word, but affordable, because it's not cheap. The technology is outstanding. Cheap implies that it's poorly made, but it is. We want to push the cost of goods so low that we can now distribute these in a hierarchical fashion, like basically in Kenya. And what's cool, I actually got to meet the Ministry of Defense there, and he talked about the hierarchical fashion of how they distribute stuff. I mean, just getting him the things he needs, set up an entire PAC system through our system, and go through the Ministry of Medicine, Ministry of Health, supply them with our devices, set up a digital PAC system so they communicate, so that when you're treating patient A and they maybe go to your partner in another part of Africa, they can have that system and you can upload those X-rays. You guys can talk through the platform, basically to digitize Africa by affordable portable devices that are battery powered and durable, that can be passed from hospital to hospital, that all share a common platform and all share a common PACS, so that we don't even have that in the US. Like if I get a patient from Boston who comes down to see me, I can't even look at their freaking X-rays. I have to take a new X-ray. The continent of Africa, if we can do this right, we'll have a secured PAC system that communicate before the US can, because we're so scattered. So that's our goal. Our goal is to start slow. We have found that countries like South Africa are good countries to start. Their health system seems to be very organized, very hierarchical. Kenya is fantastic. The Ministry of Health told me all about how it works. And another country is Taiwan. I mean, there's a lot of countries we've been to that are sort of that perfect alpha setup where we can supply them grants, large scale, multi-million-dollar grants to afford the devices and distribute them easily, because they package in a suitcase. I mean, it's not like you got to ship a giant X-ray suite. There's no build out. You don't need a radiation room. They can literally be shipped overnight to the places that need them. Push buttons, just like an iPhone. You turn them on, they get started. They have online training sources, and then everyone's on the same page. So if you're over there in Africa and you're taking care of a complex thing, and I'm on the app, we have an app that you can literally send me a message. I can look at it, and across the globe, I can tell you what I think and what I would do. So what we're doing is we're connecting people like you and me who live halfway around the world to a simple app, and just trying to advance the conversation and education. Like there may be something that I may have a question on that I don't see, and I may be able to use the app to share and collaborate. And I think really that's the goal. The goal of ours has always been to make access at the point of care. It's never been to make a bunch of money and retire. It's always been about doing the right thing, making our jobs easier, but also really fostering collaboration. And I think that is our ultimate goal with our African initiatives and our Indian initiatives, is to make super affordable X-ray that we can distribute at a large scale and create a digital platform that we all communicate on.
Yeah. Is it possible to use it for any other body part?
Well, the FDA, I mean, right now we're applying for shoulder and spine. We will create devices that are larger in scale to get to chest and lumbar spine. That is all in the works in the future. But we have to continue to do FDA applications for that. So yeah, that's all in the plan. I think chest would be huge. Chest would be great. Chest would be great because you know better than I do about how many people just need a simple chest screening.
Yeah, I was just thinking that because especially when it comes to primary healthcare, which is
Of course.
how most of the population on the African continent actually get access to healthcare.
Yeah.
And if you have access to portable chest X-ray or portable X-ray machines, then it's a game changer.
We think we can get X-ray powerful enough and portable enough to not only put it in the hands of doctors like you to get chest for screening, but also like start embedding them into the hospital beds themselves or the ceilings from a bunch of hospital beds, so you can call on itself. I mean, we were talking about a 6 pound detector that can be manipulated and moved in space. It could probably come from an arm, and then you can embed the detector literally into the bed, so you don't have to have people running around the hospital trying to get X-rays here and there. So we want to make it extremely portable, also very affordable. But those are all the next initiatives for next 2 to 3 years to make it faster, safer, more portable, and then push down the cost of goods by doing a lot of stuff in house. It's really just about accessing it, because 2/3 of the world, as you know better than I do, don't even have access to simple X-ray. When we were doing our mission work in India, in a place called Salem, which is like 8 hour train ride from Madras, or um, it was. I mean, we didn't even have electricity in the clinic, and if we sent people for an X-ray, it was, I think, like a 5 hour car ride for the closest X-ray, and that patient's not coming back in time to be seen. So I mean, you just can't have it. I mean, 2/3 of the world does not have access to simple X-ray like we do.
The It's battery powered, right? The
Yeah.
OXOS.
8 hour battery life. Yeah. 8 hours.
Mm. It will be very interesting to see how it would be used in Africa,
Mm-hmm.
because it's not only a issue of power, but also issue of internet connectivity.
Yeah. Yeah.
So that would be another challenge. But then again, unless you rolled it out and then it's in the field and being used, you won't be able to have that feedback
Yeah.
uh, in order to improve on design or really anything else. So.
I'm glad you brought that up. There's a thing we're working on right now with our own antenna, our own radio, our own Bluetooth. So part of the problem that, see, this is about an hour ago we were talking about how you try new things, right? So when we went to Canada, we realized pretty quickly that they have different Wi-Fi than the U.S. So we realized pretty quickly that as we proceed to other countries, it's going to be a whole set of software changes that can be mitigated by understanding the implant, putting a radio in it, putting a a Bluetooth. There's all certain things that we're going to unleash in this thing that to get around all the barriers with Wi-Fi. And I think I'm glad you mentioned that, because those are things that we certainly anticipate are going to be problems, particularly in areas that just don't have cell phone towers or Wi-Fi. But we have currently 3 different solutions we're working on for austere environments. And I'm talking about places that are like, I mean, extreme elevations, extreme like heat, because we want this to be able durable to go enough in any austere environment and be far away from like Wi-Fi connections and still be usable.
One of the things, it just came to my mind when we're talking about this, but one of the challenges that we usually have with some medical products is we don't have manpower to do the maintenance work, or if it breaks down, to do the repair work.
Yeah.
So like, is it easy, as it is easy to use, is it easy to maintain? Do you plan to train people in
No, no,
maintaining?
no, no. So that was a big part. So so when our mini C broke down one year, I think it was my second year, they had to get a guy from New Jersey to fly down and spend a week to fix it. So our surgery center was without a mini C on for like a week. That's devastating, because I'll do 40 surgeries a week in my surgery center. Other guys and gals can't. They have the same bottleneck. So, I mean, we had to change our whole surgery day, and we had to cancel surgeries because we just didn't have X-ray. So that cannot happen. For us, The thing that we worry about breaking down is the detector. The detector is super sensitive. It's a cesium iodide silicon detector. So if that gets cracked or whatever, it could be a problem. So we really keep with each iteration making it super durable. We have one now you can step on it, you can drop it. We've done countless drop testing. We've put it through heat, through cold, through water. I mean, we're making it super durable. The X-ray tube will literally last hundreds of thousands of images. Uh, we don't know the life on it yet because we haven't been out that long. But I mean, typically the life cycle on an X-ray tube, that's not really going to be the first thing that'll break. It will be more the detector, right? So the advantage of us is that what we want to do is if ours breaks, well, number one, we want you to have a backup. So if yours breaks, you got a backup. You just go to the shelf. Number two, if it breaks, you put it in a box and ship it back to us, or you ship it back to your distributor in Mombasa or Nairobi, and we get you one that day. The guy's driving out that day and dropping you off a new box. So when you break your iPhone, you crack it or wherever, you go to the next store and they fix it for you. We don't even want you to fix it. You just put it in a box and send it, and you call your distributor that day, and they give you a brand new one, or you have one on backup that's treated another clinic. But the idea is like an iPhone. You put it in a box and ship it back to us. We give you a new one. The service is very key to us. Yeah.
Yeah, wow. Like I said, even the first time I saw it, it was very exciting because I was like, oh my god, because C-arms and all those things are very expensive, and like you said, very bulky as well.
I,
So it has its own limitation, and the amount of radiation exposure, and the requirements for um to make sure the radiation doesn't go out, just containing
yeah.
it. It's a whole work. So, and it costs us money and it costs us time. So when I saw it, I was so excited because I'm like, oh, this is such a useful innovation. I can see it being used and adopted everywhere, without a doubt. So it's
I
very
think
exciting.
I
Yeah,
think
I'm very excited to see.
so. One of the things that you didn't know this at the time, but we were using, I was asking you sort of, I don't know, cryptic questions at the time when you were using it to be like, okay, I was asking you about it, and I took all of your feedback to heart. You should see our next device. Our next device is completely different. I even went as far. We went as far to pull female surgeons to find out what was the ideal weight, because we were getting some women were saying it's a little awkward to hold it. So we actually changed the ergonomic design to hold it in a different path, because men and women are a little bit different, and men seem to like to hold it that way. Women learn to hold it that way. It was just so we made it do both ways. And I encourage you to go on our website to look at the new design. It won a Red Dot award. If you're familiar with Red Dot, that is a industrial design. And that's a really good company, by the way. I mean, the winners for Red Dot awards are companies like Figure and like Microsoft and Sony. I mean, there's these like really big names up there. Bissell, the vacuum one. I mean, it's just like people who think of like industrial design and how to create things that are super. You ever look at a product and you're like, wow, they really put a lot of time into the form factor of this.
Yeah.
So we did. I literally interviewed thousands of surgeons. I was like, tell me what you think. Is this heavy? Is it not? Do you like it? We literally emailed everyone. We had feedback on everyone. And a lot of people that first device has been completely changed based on your feedback. And I was asking you cryptic questions. You didn't know that, but your feedback helped change the device and help win a Red Dot award. Because I remember after I went to Africa, I was interviewing you and Milan. I was asking you questions at dinner. You didn't know it at the time, but in my mind, I was thinking about it. And I really got a lot of good feedback from surgeons like you, and we took that to heart and changed the design. Our next design is going to be a little bit different. It's going to be a little bit more powerful design. But one thing I want you to be on we're studying the radiation. I can't tell you what the results are because it's not published yet. But it is strikingly, shockingly safe. Like, I could not believe we were that low compared to the incumbent. I mean, my goal was to make it safe, but I don't want to say what that is until the publication is out, because no one's going to believe the founder. I can say it's safe and 100 times less radiation, whatever. Until you see the results, like I think you'll be. There's two things that are going to happen. One, you're not going to believe it. You're going to be, I can't believe it. I can't believe the radiation is that low. And number two, or you might say, I can't believe the radiation is that high on the other ones. So I mean, there's two ways you can go about it. But as someone who values my eyes and my thyroid and my, my
Oh
life,
yes.
I really am kind of appalled at how much radiation we're getting day in, day out. So one of my goals, if I had to list my goals for OXOS, is one, get it in the hands of you who are doing great things in a different continent, get you a platform and a pack system so you can communicate with the rest of the world, make it so you don't always need Wi-Fi. Those are big things. Make it a form factor that you can appreciate and take with you when you go to your rural clinics. Those are the first goals. The second thing is really just dampen the radiation. Like make it so safe that you wouldn't even consider wearing lead in some cases. So that's another goal that we have. And then third, make it super affordable. Like we can when we start in-housing stuff, we could probably get the cost of goods lower and lower and lower, which I think is really going to help with our mission of creating access for places like Africa and India that really need it. So in that sort of linear pattern, that's really what our main goals are.
Yeah, that's fantastic. It's so funny that you mentioned that because last month was October is Breast Cancer Awareness Month,
Yeah.
and one of the discussions that we had as female orthopedic surgeons was shielding. And one the things that were being mentioned was that the late aprons were, especially the ones we get from Africa, which is mostly from donations, they are not really fitted to the
Yeah.
female body.
Yeah.
We get a lot of exposure, and we
Uh-huh.
don't have thyroid or eye covers, everything. So it was one of the biggest issues that we talked about. So it makes me happy that you guys are considering all these factors from the get-go, which makes it very promising.
The risk for breast cancer in a female surgeon or orthopedic surgeon is far higher than standard population. I mean, I don't remember. I think it's 6 to 8 times higher, strikingly higher. That was the number one concern for our female surgeons. Oh, and our male surgeons too. We care about you guys. And then number two, cataracts. I mean, we've got guys and gals in their 40s getting cataracts, and then weird sarcomas in their hands and thyroid. So thyroid, hands, breast cancer, cataracts. Um, and you'd be surprised what happens when you put the X-ray under the table. It actually creates this it creates this massive like scattering that goes all over the place and not places you want it to go to. So
Yeah.
we did not want to create a problem where we're putting the detector underneath the table because you're creating a scatter effect that's literally exposing your entire lower body to that. So we wanted to make it sort of more ergonomic in the OR to make sure that the hand or the extremity is directly on the detector, which does two things. It decreases parallax, which is a false sense of size and positioning. It's like getting an AP of the chest versus a PA. The heart size looks different. The shape of a screw or the position of a fracture or the shape of a bone will look different if the most accurate image you can get is when the anatomy is actually on the detector. When you're doing it, I see surgeons do it all kind of weird ways where they have the detector way under the table. You're getting a false image. There's a lot of parallax, but you're also getting far greater backscatter because it's going through interference. You're sending that photonic radiation everywhere. So we wanted to dampen that by making sure it was streamlined. The safest way to get it is get as close as you can with as little voltage and as little current. So drop the power, get it close, not have to fire up the power, and put the anatomy right on the detector. So if you're following those tenets, you're going to get an accurate image, you're going to get less parallax, you're going to get far less radiation, less backscatter.
Yeah. So interesting. No, but it is because, I can see it. I can imagine using, because I've already used it in a way. I've seen it being used. So whenever when you talk about these things, I'm like, okay, so I'm imagining what it would look like. And I did go and see your company's website, and I've seen the design. So I'm just very excited for it to, be introduced to Africa in a larger scale, where I think it would benefit way more people, and not just patients but also physicians as well, and surgeons as well. So yeah, I'm looking forward to it. And kudos, more power to you, and congratulations on
Thank
the
you.
red dot recognition. That's huge. And people like you who thrive, who work every day to make you know to provide better patient care, is not just for your patients immediate in your immediate clinic, but across the globe. So yeah, thank you for that, and thank you for coming on the Everyday Leader. It's been fantastic.
Thank you. Appreciate it. It was fun.
Yeah.
As soon as, well, as soon as we get a bunch, I'm gonna send one to Africa and give me feedback. Tell me my baby's ugly. I'll make it less ugly.
100%. I do remember because it was heavy, and when
It's not anymore. We lightened it up.
you
Yeah.
all right, thank you so much, Greg.